All right, so we're going to get grand round started. It's Dr. Amber Dawson. She is a fourth-year med student. She's fulfilling one of her requirements for graduation, which will be pretty quick here. But she's going to be talking about pediatric hypertension, which is definitely a hot topic, especially with all the obesity that we see in the country, especially in Louisiana. And so we're interested to hear what Dr. Dawson has to say.
Thank you, Dr. Cooper. Okay. Good morning. We'll get started with pediatric hypertension. So I have no relationship with anything related to the content of this activity, of this topic. So my objectives basically are to learn more about hypertension, how we can diagnose it, how to treat it, recognize any complications, and also I added a little bit about who's allowed to participate in sports and how we talk to them about their hypertension. So hypertension is defined as average systolic and or diastolic that is greater than or equal to the 95th percentile for sex, age, and height on 3 or more occasions. Pre-hypertension in children is defined as average systolic or diastolic blood pressure levels that are greater than or equal to the 90th percentile but less than the 95th percentile. And then as with adults, adolescents with blood pressure levels greater than or equal to 120/80 should be considered pre-hypertensive. And then there's the other term, which is we use as white coat hypertension, is defined as a clinical condition in which the patient has blood pressure levels that are above the 95th percentile when measured in a physician's office, whereas the patient's average blood pressure is below the 90th percentile outside of a clinical setting. That's why you won't see us wearing white coats on peds wards and everything, because we don't want them to get nervous. So usually what we do here is at the 3-year visit, they'll always have a blood pressure measured when they come to clinic. And then obviously the preferred method of blood pressure measurement is auscultation. And that's what a lot of the tables are based on, is the auscultatory method. And the correct measurement requires a cuff that is appropriate to the size of the child's upper arm. And elevated blood pressure must be confirmed on repeated visits before saying that the child has hypertension, like we said before, 3 or more readings. And then measures obtained by oscillometric devices that exceed the 90th percentile should be repeated by auscultation. So this is when they talk about proper cuff size, they want the bladder width, which is this area, to be more than 40% of the mid-arm circumference, and then the bladder length of the blood pressure cuff should be 80 to 100% of the arm circumference. They have specific measurements also for in different age groups, and the equipment necessary to measure blood pressure in children includes child cuffs of different sizes, and must include standard adult cuff, large adult cuff, and thigh cuff, if you want to look for the difference in the upper and lower extremity blood pressure. So these are just a list of the conditions when it's an exception, when children less than 3 years should have their blood pressure measured. History of prematurity, very low birth weight, any neonatal complication requiring intensive care, congenital heart disease, UTIs, hematuria, proteinuria, known renal disease, solid organ transplant, malignancies, treatment with drugs known to raise blood pressure, other systemic illnesses associated with hypertension like neurofibromatosis, tuberous sclerosis, etc., and evidence of elevated intracranial pressure. So this is what usually the kids look like when they come to clinic. But their blood pressure, before measuring a child's blood pressure, we should ensure that they've avoided any stimulant medication or foods like any caffeine. They've been sitting quietly, so if we have a child that's really agitated, we want to make sure that they're in a separate room. They've calmed down, they're with their parents. I say seated with his or her back supported, feet on the floor, and right arm supported with the cubital fossa at heart level. And what they also specify is that you want to check it in the right arm because in the coarctation of the aorta, the one where it's distal to the subclavian artery, it might lead to false or low readings of the left arm. So once we have that elevated blood pressure reading, we want to confirm that it is actually elevated. Like I said, we want to auscultate. And another thing they were talking about is that a lot of kids, the carot cough sound, it actually is really sometimes can go all the way down to 0. So that can also help with your auscultatory method. Sometimes you can use the fourth sound where it becomes muffled to use that as your diastolic. And then basically the blood pressure measurement can fall at subsequent levels due to accommodation, like when they're not anxious, they're not screaming, or sometimes when they get a little more adjusted to clinic visits, it'll be different at the next visit. Regression to the mean. So you want to get an average, except when you're concerned about severe hypertension, and obviously that needs to be treated. But more precise is when they have an average of multiple blood pressure measurements taken over weeks to months. So ambulatory blood pressure monitoring is when we use a portable blood pressure device worn by the patient, which records blood pressure over a specified period, like about 24 hours. And they're saying that's very useful in the evaluation of hypertension in children. It's especially useful when there's the concern of white coat hypertension, parent drug resistance, and sometimes if they're having hypotension when they're on antihypertensive drugs. And ambulatory blood pressure is also useful for evaluating patients where you want more information on blood pressure patterns, like in CKD, diabetes, and autonomic dysfunction. So this is one of I had gone on this website where they listed the ambulatory blood pressure monitors that are acceptable. Most of them are like the ones we see in clinic. They have a portable monitor with them, and they're supposed to be used around the arm. And usually the wrist blood pressure monitors were not really recommended. They're not as accurate as the ones that we're recording, like the ones in clinic. But this one was one of the ones that I saw that it said that it can be used. It's called SomnoTouch, non-invasive blood pressure. But otherwise, the other ones look basically like the ones we have in clinic, and they're portable. So they've also staged blood pressure. Stage 1 is for blood pressure levels that range from the 95th percentile to 5 millimeters above the 99th percentile. And then stage 2 is for blood pressure levels that are higher than 5 above the 99th percentile. And I'd just like to add, like we said on the previous slides, that if an adolescent has blood pressure of greater than 120 over 80, then they are considered to be prehypertensive, and then even if the value is less than the 90th percentile. And usually you see that around age 12, or diastolic, like you'll see the systolic at age 12 and diastolic in age 16. So this is just an example of the blood pressure chart. We've all seen them in Harriet Lane, and we refer to them when we're looking for blood pressure measurements when we're seeing a child in clinic. Like you can see, they have the systolic, it's different ages. This is for boys, they have separate one for girls. This is how you'll, after you see somebody, you've done the auscultation, you've confirmed the blood pressure reading, and this is how you'll tell what percentile they're at and what category they will be included in. So this was a table that I got from the 4th edition of the blood pressure for children and adolescents. And it's for less than 90th percentile, it's normal. You'll recheck at next appointment. Basically, you'll encourage healthy diet, sleep, and PA's physical activity. You don't need any medications for that. Pre-hypertension, like we said, is 90th to less than 95th, or if blood pressure exceeds 120/80. We'll recheck in 6 months. Weight management if overweight. Start physical activity and diet. And there's really not an indication for medications unless there's CKD, diabetes, heart failure, or left ventricular hypertrophy. Then stage 1, there's 95th to 99th percentile plus 5 millimeters mercury. Recheck in 1 to 2 weeks or sooner if patient is symptomatic. Weight management if overweight. Start physical activity and diet. And then based on the next table that we'll see, you'll need to start medications. Stage 2 hypertension greater than 99th percentile plus 5, and then evaluate or refer to source of care or immediately start treatment. Weight management if overweight, start physical activity and diet, and initiate therapy. That'll be immediately start therapy if they're symptomatic, basically. So the indications when we want to start medications is symptomatic hypertension, headaches, vomiting, any other systemic effects that they may have. Secondary hypertension, hypertensive target organ damage, diabetes type 1 and 2, and persistent hypertension despite non-pharmacologic measures like weight loss and physical activity. So, and then we also want to evaluate for confirmed hypertension. Once we've said that, okay, this child has hypertension, we want to dig more into the history. We want to get the identifiable cause before we start them on any medication. Sleep history is important, to find out if they're snoring. We have the BEARS questionnaire, family history, diet, smoking, alcohol, and some findings on physical exam that we can say that if this person is predisposed to hypertension. BUN, creatinine, electrolytes, UA, and urine culture to rule out kidney disease. And then CBC if we want to rule out anemia with CKD, and renal ultrasound for any scarring or congenital abnormality. And these are for kids with the blood pressure greater than the 95th percentile. We have to do these examinations or these testings. Then also, along with blood pressure, we'll do a lipid profile and glucose for overweight patients with blood pressure in the 90th to 94th percentile, and everyone with those with greater than 95th percentile. If you're suspecting any drug if you're suspecting any drug activity, if they think they're using drugs, you do a UDS, and if they report that they're snoring or having signs of sleep apnea, you want to get a sleep study. And for target organ damage, we order echocardiogram, and we can try a retinal exam, but probably ophthalmology will be a better bet since they can see better. So for primary or essential hypertension and looking for comorbidities, usually the mild stage 1 is often associated with the family history of hypertension or CVD. Obese children are about an approximately 3-fold higher risk for hypertension. They talk about some studies that don't really show like a very significant risk or a very significant association, but they did this very large study, and they do see that as the child is getting more, with children more obesity, they are they usually do have high blood pressure. And then and primary hypertension will usually be present with other risk factors like low plasma HDL, elevated plasma triglycerides, and abnormal glucose tolerance with like insulin resistance. And because of the associations with hypertension and the frequency of sleep disorders, especially among overweight children, we need to get a good sleep study. So secondary hypertension is more common in children than we see in adults. Usually in adults it's essential. Very young children, children with stage 2 hypertension, and children or adolescents with signs with systemic conditions should be evaluated more extensively than those with stage 1. And we want to look at signs and symptoms looking for renal disease, any heart disease, or any other systems like endocrine or rheumatologic, like we'll see in a minute. So on more history, mostly a lot of these, like for any other disease, we need history and physical examinations. We want to address family history. We want to look at their, like I said before, UTI, snoring, family history, renal disease, diabetes, and also we need to get a good drug history, like any over-the-counter, any prescription drugs that can possibly cause hypertension, and to see if we can maybe use any substitute in its place. And then a lot of, like if there's a suspicion, like if there's any athletes that are using possibly enhancing drugs to enhance athletic performance. So these are some examples of physical exam findings that we'll see. These are for the eyes, and these are more like stage 3 and stage 4 retinopathy, when you see the cotton wool spots and the flame hemorrhages or the heart exudates. Before that, it's usually maybe arterial tortuosity. And they say that once you do treat the hypertension, these effects or these physical findings will disappear. And then this, we're trying to look for adenoidal hypertrophy for those who snore or have sleep apnea. This is acanthosis if we're thinking of diabetes. The moon phases for Cushing's, butterfly rash for lupus, and this is supposed to be like web neck for if we're thinking of Turner's. The first thing, obviously, physical exam will include the vital signs. If the child is tachycardic or continuously tachycardic, we want to rule out hyperthyroidism, pheochromocytoma, neuroblastoma, or if they have decrease in lower extremity pulses, you can't feel the femoral pulses that well, you want to think of a coarct. And they said that even if the child is obese, that being a reason for decreased lower femoral pulses, we shouldn't use that excuse that, oh, this kid is obese, he's going to have decreased pulses. You want to think of coarctation. If there's talking about pallor, flushing, they start sweating profusely, pheochromocytoma, if they have acne or hirsutism, you're thinking of Cushing's. Any steroid use, if you're on physical exam, if you hear a friction rub, you might think lupus, or an apical heave, suspecting for LVH. And any masses in the abdomen, like Wilms tumor, neuroblastoma, epigastric or flank bruit, renal artery stenosis, any ambiguous genitalia like congenital adrenal hyperplasia. And then when we confirm hypertension on these with these physical exam findings, we also want to do the blood pressure measured in both arms and a leg, with the blood pressure will be about 10 to 20 millimeters of mercury higher in the legs than the arms. So that should, to rule out coarctation. So additional diagnostic studies may be appropriate in evaluation for hypertension in child or adolescent, especially if you're thinking that there's an underlying disorder. You want to do ambulatory blood pressure monitoring to rule out white coat hypertension, abnormal BP pattern, BP load, maybe plasma renin, to look for low renin, any mineralocorticoid disease, renal vascular imaging, any renal ultrasound, if anything is concerning on renal ultrasound, plasma and urine steroid levels, and plasma and urine catecholamines, if you're thinking FEO. So the main target organ abnormality that we're looking, that is the most prominent, is the LVH. And pediatric patients with established hypertension should have echoes to assess the mass initially, and then periodically thereafter, like especially even if you've started hypertensive medications, you want to see if that, usually it does revert back to normal. And when you do see LVH, that is definitely an indication to initiate or, enhance, like increase the amount of antihypertensive therapy. We want to avoid any severe elevations of blood pressure because they're associated with adverse outcomes like encephalopathy, seizures, CVAs, strokes, and congestive heart failure. And sometimes even hypertension that is less severe can be associated with organ damage when it occurs, especially with if they have other chronic conditions like CKD, diabetes. However, they said that the exact level and duration of how long their blood pressure has been elevated, they can't really establish, when that target organ damage takes place. So, like I said, LVH is the most prominent clinical evidence and caused by hypertension. It's reported that in 34 to 38% of children can have left ventricular hypertrophy with mild untreated blood pressure elevation. And the measurement that they do is for what they're, for the echocardiogram, the cut point is 51 grams over meters 2.7, which is above the 99th percentile for children and associated with increased morbidity and mortality. So, like we said, weight reduction is the primary therapy for obesity-related hypertension. Regular physical activity and restriction of sedentary activity. They recommend to do at least 30 to 60 minutes of physical exercise a day and to limit sedentary activity to about maybe 2 hours a day. Dietary modification is encouraged, and obviously, if the family is also participating, then that will result in better and improved success. And then identifying a complication of overweight can also, when we want to kind of nip this in the bud before this happens. So if you have an obese child in your clinic, you want to obviously go over complications of obesity and like hypertension with the parents, that, instead of having your child be on these medications, that it's prevented with diet and exercise. However, obviously if they have severe hypertension or stage 2, then you want to go ahead and start medication. So indications, like I said before, are symptomatic hypertension, target organ damage, and they have increased the number of antihypertensive drugs that we can use in pediatrics since the report of the task force on blood pressure control in children was established, I believe in 1987, and they've been doing some studies with these drugs that we've already established in adults on children. But with all the classes of antihypertensives we have, it's usually the preference is, it depends on what the physician wants to use. So we have diuretics, beta blockers, ACE inhibitors, ARBs, calcium channel, which have been shown to be safe in children. And if we're thinking of the child has diabetes, then we want to use ACE inhibitors or ARBs. And they say that it's better to use beta blockers or calcium channel if a child has associated migraine headaches as well. So the recommendations are that they be started on the lowest dose recommended. They can be, this dose, like on that single medication, can be increased until the desired blood pressure goal is achieved. But we want to make sure that there are no side effects from this drug. And if we're on the maximum dose, we're not having side effects, and we're still not reaching the required blood pressure, then we want to add a second drug from a different class. And we don't usually use that many combination drugs like we have with adults, like we have with lisinopril, HCTZ, Prinzai, and those other medications. But the main one that they said that has been tested is the bisoprolol, HCTZ, which we can use in children. So the target, what are we targeting when we're starting these medications, is for uncomplicated primary hypertension, the goal blood pressure should be less than the 95th percentile for sex, age, and height. But for children with organ damage, chronic renal disease, diabetes, target organ damage, it should be less than the 90th percentile for sex, age, and height. So this is, I thought was a very helpful algorithm where, to give you a step-by-step clue of how to treat a child with hypertension. First, you want to measure the blood pressure, height, calculate BMI. If we're thinking stage 1, we want to repeat the blood pressure over 3 visits. If it's 90 to 95, less than 95th, therapeutic lifestyle change. Repeat blood pressure in 6 months. Consider diagnostic workup and evaluation if overweight or comorbidity. Normal BMI, monitor every 6 months. Overweight, weight reduction. If it's less than 90th percentile, we'll just educate. And then stage 2, we'll definitely do the diagnostic workup, or if it's greater than 95th percentile. And if they have target organ damage like the LVH, we want to consider, or CKD, we want to consider referral to either a cardiologist or a nephrologist. And then obviously drug, you can start them on, that doesn't mean you don't need to start them on a medication, you still start them and you counsel them if overweight for weight reduction. So these are some of the medications that they said that can be used in children. ACE inhibitors, captopril, enalapril, the ARBs, losartan, labetalol, atenolol, metoprolol, propranolol. Some of these are short-acting, some long-acting, and the calcium channel amlodipine or extended-release nifedipine, also, I guess depending on their insurance, which ones you can afford. Clonidine, and then the diuretics like spironolactone, HCTZ, alpha antagonists, doxazosin, terazosin, and vasodilators like hydralazine or minoxidil. And of course, before prescribing medication, especially for females, you want to make sure that if they are on a birth control pill or they basically let them know that this is teratogenic. You can't use these during pregnancy. ACE inhibitors and ARBs. And then if they are on these medications, any population, you want to check potassium, creatinine to look for hyperkalemia, azotemia. For labetalol, asthma and heart failure are usually relative contraindications. And they say in athletes it can impair athletic performance. Should not be used in insulin-dependent diabetics. Clonidine can cause dry mouth or sedation, and if you suddenly stop it, it can cause severe rebound hypertension. So for diuretics, as we know, we want to look at their electrolytes, make sure they're not losing potassium or they're not getting dehydrated. With initial starting right after therapy and periodically, usually like about 3 to 6 months after. Potassium-sparing diuretics like spironolactone can cause or worsen hyperkalemia if they're used with ACE inhibitors or ARBs. Alpha antagonists may cause hypotension. So if they're saying that they're feeling dizzy after using that, you want to talk about that. Vasodilators, they can have tachycardia and fluid retention. Hydralazine can cause a lupus-like syndrome. That's one of the medications that can cause the drug-induced lupus. And slow acetylators and prolonged use of minoxidil can cause hypertrichosis. Okay. So since a lot of our clinic, we see in clinic, they want to participate in sports, or they come in for sports physicals, and you know, they want to know, you know, can I participate in sports? I've got high blood pressure, or I'm on medication. So this was a good article in Pediatrics 2010 where they talked about athletic participation by children who have systemic hypertension. So it is one of the most common cardiovascular conditions seen in children, and provided obviously that they don't have any significant cardiac problems, and we're not worried about that. You know, we can easily treat them or manage them ourselves to a certain extent. So they also interesting to note is that the heart obviously can become enlarged non-pathologically due to high levels of training in some adults, usually males, and this is referred to as athlete's heart. But the left ventricular hypertrophy beyond that seen in the athlete's heart should limit participation until blood pressure is normalized with drug therapy. Usually another thing it's stated is that athletic heart is characterized by preserved myocardial structure, and it does not progress to left ventricular dysfunction. When they do echoes, they will calculate the left ventricular mass from the left ventricular and diastolic dimensions, the interventricular septal thickness, and thickness of the left ventricular posterior wall. And usually with those dimensions, they can rule out or they can differentiate between the athletic heart and left ventricular hypertrophy. So guidelines recommend temporary restriction for those athletes who have stage 2 hypertension until normal blood pressure is achieved. However, available data does not indicate that strenuous exercise places any athletes at risk of acute complications of hypertension during exercise or of worsening of their baseline blood pressure. So this was a chart in that article. It might be a little difficult to see, but on the vertical component is the static component of the sport, and then horizontally it's the increasing dynamic component with the increased cardiac output. Like they've shown 1A and low is like bowling or cricket or golf, and 1B is, they've said, baseball or softball. And then diagonally we'll see as its static and dynamic component is going up, it'll be like 2B is running, surfing, American football, rugby, and 3C, which is highest, would be boxing, cycling, rowing, speed skating, triathlons. These are the 3A to 3C. These can include like martial arts, sports climbing. This is bodybuilding, skateboarding, wrestling. So these are all like, once you talk to the patient, you want to know what kind of sports they are participating in. And they said basically in the dynamic component, the dynamic exercise, we're exerting muscles through joint movement. And the intramuscular force is not greatly increased as muscles lengthen and contract and joints move through their range of motion. There is a sizable increase in systolic blood pressure, a moderate increase in mean arterial pressure, and a decrease in diastolic pressure and total peripheral resistance. So that's for the dynamic component, that's requiring more cardiac output. And then static exercise, exerting muscles without joint movement, is relatively large intramuscular forces are developing without much change in muscle length or joint motion. The systolic, mean arterial pressure, and diastolic pressure increases significantly and total peripheral resistance remains unchanged. However, it is that this acute increase in diastolic blood pressure that is concerning to the experts, as well as increase in muscle mass that may elevate the resting blood pressure. So that would be in the column, like increasing for the static component. Some of these that they have signs with like the cross sign, it's like for roadieing or surfing, they'll say that like there's increased risk of syncope, and like you want to caution your patients who are hypertensive to when participating in these kind of sports. So the young athlete with hypertension, regardless of severity, we need to encourage to adopt healthy behaviors, including obviously exogenous androgens, growth hormone, illicit drugs like cocaine, alcohol, tobacco, non-prescribed stimulants, some over-the-counter supplements, especially those that contain ephedra or other stimulants, and excessive consumption of energy drinks and caffeinated beverages. And they even talked a little bit about how football coaches encourage their kids to gain more weight, causing them to be more obese, and we want to kind of talk to them about developing a more healthy lifestyle. So the recommendations by the AAP for these athletes is lifestyle modification, including daily physical activity and well-balanced diet. Presence of prehypertension should not limit a person's eligibility for competitive athletics. So if they do have prehypertension, you basically measure their blood pressure every 6 months. It's not going to keep them from participating in competitive athletics. Stage 1 hypertension in the absence of end organ damage, including left ventricular hypertrophy, should also not limit a person's eligibility for competitive athletics. However, and they should have their blood pressure rechecked 1 to 2 weeks to confirm hypertension, or sooner if they are symptomatic. Then with stage 2 hypertension in the absence of end organ damage, including left ventricular hypertrophy or heart disease, should be restricted from high static sports, classes 3A to 3C, which was in that chart. Needs to be restricted until their blood pressure is in the normal range after lifestyle modification and or drug therapy. When hypertension and other cardiovascular diseases exist, they are usually based on the type and severity of their heart problems. Medications like caffeine, drug, tobacco, and stimulant use should be reviewed with any athlete with hypertension, because like with what effects these substances may have on blood pressure. And they also say that sometimes the use of diuretic medication and beta blockers have been prohibited by some athletic governing bodies, and all medications should be registered with the appropriate sports governing body to request therapeutic exemption when appropriate, if you can't switch them to another medication. And then they say that usually if you're restricting sodium intake is typically recommended for those with hypertension. For some young athletes, rehydration often requires deliberate intake of additional salt-containing fluids and foods to ensure greater body water retention and distribution to all fluid compartments. So the current sodium recommendations for youth are about 1.2 grams per day for children 4 to 8 years of age, 1.5 grams per day for older children, and about 2.4 grams per day for adults. And care should be taken to appropriately diagnose and monitor athletes who are at high risk for hypertension, such as obese athletes and athletes with spinal cord injuries due to autonomic dysfunction. And these are my references, just a few. So the main reason why I wanted to do this is, like, currently right now we don't seem to have any nephrologists. Might change in the near future, but you know, the main thing is we want to, you know, basically diagnose. We want to see what level of hypertension they are. We want to follow up, you know, as the guidelines, about 6 months, you know, as needed. Obviously, counsel them on weight. If that's not working, try something else. Try to get the family involved. I mean, we're all, especially as pediatricians, we're all pretty good at that, involving the family, and obviously getting a family history. They know what it's like to take medications, being short of breath, having chest pain, and we want to kind of tell them that you don't want your child to be like that when he or she grows up. And most of, like, the medications that I was going over are relatively safe. We want to rule out any allergies. Like, a lot of times, like, well, sometimes with ACE inhibitors, you know, you want to worry about angioedema, and obviously, you know, update their profile for allergies if they're allergic to that. But relatively, these medications are safe, and there's no, and once we've diagnosed them, once we said, yes, this person is hypertensive, and of course, if they have, we always do the echoes, we get the UAs, we look for renal ultrasound for any problems or any renal artery stenosis. Usually, from their guidelines, it's basically if they have any end organ damage, that's when we want to refer them to any specialties. But even before that, we want to make sure that it's controlled. We have them on appropriate medications. For diabetics, if they're not on lisinopril, we want to know why are they not on lisinopril. We have their labs. If they have any proteinuria, start them on lisinopril. And then, but they also said for, like, ACE inhibitors and ARBs, usually it's the FDA is only approved for, like, kids 6 and above, and with a certain creatinine clearance. So we want to look at all the guidelines and make sure that and I think Tanjay is doing, like, a QI project just to, since in EPIC, you know, it only shows red, like, for certain age groups, but obviously we want to look at those vitals, look at Harriet Lane, see what category they come in, and then, you know, do the auscultation, change the vitals, saying that, you know, on auscultation this is what came of, and of course periodically recheck. And then of course, like Jency was talking about, you want to make sure that they're compliant with those medications after that. So, but hopefully this should help you all. Yeah.
Does it talk about, since, you know, we don't have a pediatric nephrologist right now, a lot of us are initiating therapy and stuff, so does it talk about initiation choice of therapy in regards to, like, before you completed the workup? Because I know, like, in clinic last time I saw a kid who had an echo done, but he hadn't had a renal Doppler done yet. Mm-hmm. It was ordered, but it wasn't completed. He mm-hmm. started on an ACE inhibitor. Mm-hmm. And if he does have significant renal artery stenosis, mm-hmm. but putting him on ACE inhibitor, you kind of worsen the situation. Mm-hmm.
So, like this, you know, like I was saying, if you're thinking that they have maybe migraines or they're having, like, tachycardia or palpitations, sometimes you can start them on a beta blocker, labetalol or metoprolol, or even a calcium channel blocker. There's no contraindication to that, like, you know, they don't have asthma or something. But yeah, you can consider, if you don't want to, if you want to wait till the renal ultrasound, you can always put them on some other medication. And then that's another thing. But for diabetics, if they are on a ACE inhibitor already, if you want just to complete the diagnostic evaluation, you can get a renal ultrasound, because if obviously if that ACE inhibitor is not working, if their blood pressure is getting worse, you want to change or think of underlying causes like that.
I just recently heard that Baton Rouge lost their pediatric nephrologist, and I think New Orleans only has 2 right now. So for the state of Louisiana, there are only 2 pediatric nephrologists. So it's going to be important for you to know how to manage a child with hypertension and to have a good plan, especially as you get out into private practice, because it's going to fall to you and there aren't going to be pediatric nephrologists for you to send your patients to. Thanks.